All right, you're recording, Dr. Charpie.
Come over here.
Farm audience.
Come on in. Scoot in, everybody. Everybody get on the camera. You might be famous someday.
I was asked to speak about palliative care by, I guess I'm not really an expert in palliative care, but I was preparing a talk that I was supposed to give in a couple weeks to the Society for Critical Care Medicine about end-of-life care, and specifically focusing on severe childhood illness that is carried through to adulthood, and I thought congenital heart disease kind of qualified for that. So most of my talk is about congenital heart disease, and I think I'd like to try to do two things today. First of all, share some data about congenital illnesses, survival, and palliative care. And second, kind of get you guys feedback about what you think about the talk, because I have to give us a couple weeks, and frankly, I don't know if it's on task or not. So I thought I would use some of the slides that I've created as a way to sort of stimulate some conversation, but this is not intended to be formal. I'm just interrupt and ask questions if you guys have any specific questions. But as most of you know, for congenital heart disease, 1 in 100 children is born with congenital heart disease. It is the most common birth defect. And over 90% of these kids are now living into adulthood, which is what we're seeing now more and more. And if you guys look at our schedule for this week, we have several patients who are over 18. So the complications that these kids who become adolescents and adults have are now only becoming apparent in this day and age. And we're fortunate now that survival with congenital heart disease in a program like this is well over 95% for all congenital heart disease. So we're fortunately dealing with kids who are surviving to adulthood, but now we're dealing with what the long-term complications are of their neonatal surgeries. So it turns out that a fairly significant proportion of these children are at risk for premature death, and that death is usually cardiac related. And in a recent study, they showed that about 20 to 40% of adults with congenital heart disease who die of heart failure. So we're trying now to get a better handle on what are the risk factors for death in this very complex and heterogeneous group of patients. So in terms of end-of-life care, there are pretty good end-of-life care guidelines that have been established for acquired heart disease. So those patients who have coronary artery disease, who have heart failure from valve abnormalities, things like that have been studied for some time. And there are consensus guidelines that are used to figure out what are the risk factors for death in those patients. Unfortunately, no such guidelines exist for adults with congenital heart disease. But from the acquired heart disease group, there have been some publications that have established a couple of guidelines. First of all is that almost uniformly patients prefer that we have discussions about end-of-life care early in their disease. It's really important to them that they have optimal thought processes, cognitive function when they make these decisions. And opposite to what some caregivers may think, to bring this up early on is not something that patients are against. They're actually very much in favor of that. It allows them to decide very comprehensively what kind of care they want, what kind of care they don't want, and they can make these choices in a very informed way. It's been shown through palliative care literature that these are associated with improved outcomes. Now, again, this is end-of-life care, so the outcome ultimately is going to be death, but the quality of life as assessed by the patients and their families has been shown to be much better when these discussions happen early on. Again, though, no current guidelines exist for patients with congenital heart disease. There was a study published in 2012, this past year, in palliative care medicine, that looked retrospectively, so looked back at a study at patients with congenital heart disease, adults who died between 2000 and 2009. They excluded patients who died outside the hospital or perioperatively, so they're really looking at patients who died of heart failure, who died of a natural progression of their congenital heart disease. And they tried to just get a assessment of the treatments that were provided prior to death, as well as any documentation of end-of-life discussions. So that's really where we fit. And when you look at these patients and you describe this patient population retrospectively, and this was now 48 patients that they looked at, the age of death for these patients on average is about 37 years. So that's much younger than what we deal with acquired heart disease. This is part of the obstacle that we run into. Many of them were married, about 40%, or had a partner. enough, 90% of them had a parent that was still alive. So again, that makes the decision-making that much more complex, because how parents superimpose their concerns, their fears, their desires on top of the patient may be very different in certain groups. 94% of the patients had what was classified as moderate or greater disease complexity, and this is actually in American College of Cardiology, American Heart Association consensus definition of congenital heart disease: what's simple, what's moderate, what's complex. Greater than 90% had moderate or greater disease complexity. 80% had had previous cardiac surgery. 90% had had a previous major adverse cardiac event. And 56% of these patients had already had a previous admission due to heart failure. So this is a sick group of patients. The point being that as you look back at these 48 patients, and again, this is a publication from this year, so this is relatively new data, these are not the kind of patients that would have caught us by surprise. These are patients who have struggled for a while, who many of us, if we step back, would say these patients are at risk for premature cardiac death. 42% of the patients had had a prior heart transplant assessment as well. So what were the spectrum of underlying diseases? About 15 or so of these patients had cyanotic heart disease. Another 10 or so had transposition. 7 had Fontan. 5 had aortic stenosis, and then the rest a smattering of a variety of different diseases, from tetralogy Fallot to Marfan's to coarctation, etc. Now this, again, is a publication this year in a patient population from 2000 to 2009. I think if you looked at our patients now, you'd see a much higher population of Fontan patients. This is what we're dealing with now. These are the ones who are becoming adults. Repaired tetralogy Fallot, another disproportionately high group of patients, where you're going to see them up there as pulmonary valve replacements, but they're former TENS. And I think the cyanotic heart disease is becoming less and less common because many of these patients are now repaired early on. So the demographics are changing a little bit, but again, I think it's a relatively reasonable representation of what we're dealing with in 2012. So now remember, the goals were to look at what care was provided to this patient group before they died, and were there end-of-life discussions prior to when they died. So looking at these 48 patients, the circumstances of their deaths, 50% died of heart failure or circulatory failure. 13% died of pulmonary hemorrhage. Interestingly, though, 67% died while in the ICU. And of those who received medical management prior to death, 44% were on a vent, 15% were on dialysis, and 52% died during CPR. So a fairly large percentage of these patients died in the ICU and had interventions performed on them before they died, even though, based upon their admission criteria, and again, we're removing those who died unexpectedly outside the hospital, and more who died perioperatively. So these are patients, again, who've already been admitted, already known to be sick. We're intervening in an awful lot of these patients who already have known diagnoses, known admissions, a intractable heart failure, and a curve that, if you step back, is pretty obvious, I think, to many caregivers. Documented discussions about end-of-life care occurred in only 10% of the patients, so 5 patients had a discussion with a caregiver about end-of-life care. 3 of those occurred prior to admission, so only 2 occurred during this sentinel admission. Any discussions with substitute decision makers, so with family members, that occurred about 40% of the time, but looking at the data closely, those occurred very late during these hospital admissions, and they were almost uniformly about the futility of ICU care. So basically, it's when we've already gotten to a point where we all know what's going to happen, and we're just having that conversation. In fact, it occurred on a median 17 days after admission and only 2 days before the patient died. So very late in the hospital, of course. Referrals to specialized end-of-life care systems, so in our system, mostly palliative care, that occurred in only 10 cases. About 20% of the patients. Interestingly enough, though, those who were referred to palliative care, none of those patients got CPR. So again, if you want to look at this, the palliative care model was successful in those who were referred, but very few were referred. Now Now, the reason why I brought this up, this particular publication, is it's about the only one that I've seen in a congenital heart disease population that has looked at a relatively representative group of patients and really described what has happened to them. And I think if you did a similar kind of thing in our patient population, you might see a very similar outcome. So the question really comes down to, why is palliative care or end-of-life care delayed and denied in this patient group? I think there's a couple things that come from the data. One is, these patients are younger. And no matter how much we want to kid ourselves, I think it's very difficult to have these conversations when you're talking about 20, 30, 40-year-old patients. Most of us don't think about those patients as end-of-life care. And again, the mean age of death for these patients is 37. That's very different than if you looked at an acquired heart disease population, where it'd probably be, early 70s. Also, over this time frame, we've had dramatic advances in life-prolonging care. So last night we put a patient on ECMO. AICDs, cardiac resynchronization therapy, ECMO, VADs, transplant, you think about it, it's all been really fully developed for our patients in the past 10 to 15 years. So I think we all look at those as potentially life-saving interventions, and so it tends to delay the conversation about end-of-life care. Maybe appropriately so, but it's hard to put a patient on a transplant list, have that family have that hope, have that patient have that hope, but at the same time have a conversation about end-of-life care. It seems like you're kind of working both ends of the street. And I think certain families may respond that way too. So that can be a very difficult kind of transition to make. Lastly, I think it's very difficult, no matter how expert we think we are, to recognize sort of the dying phase for our patients. I know there's oftentimes a fair amount of angst between the cardiac ICU nurse and the physicians or nurse practitioners who are taking care of chronically ill patients. And that's partly because we're in there for the longest time trying to take care of a patient with the idea there's going to be a good outcome. And at some point or another, we recognize that maybe that outcome's not going to be so good. Maybe it's a prolonged hospitalization, maybe it's a chronically ill child. And then you may transition to, it doesn't look like this patient's going to survive. But not everybody catches up to the same decision making at the same time frame. And really truly trying to say when is care futile is a very difficult thing to ascertain in our patients. And it may be different for every single lesion, every single patient. We have no reliable tools or risk models to tell us, given a certain patient, given certain comorbidities, given a certain diagnosis, what is their risk of dying? Nothing like that exists. If we had that, life would be a lot easier in terms of these end-of-life care discussions. There are these kind of models in acquired heart disease in adults. And so you'll hear a lot more about that if you spend time at the SICU or the MICU or some other place where they have fairly established guidelines. And they know what the risk of liver failure is with coronary artery disease. They even know what your risk is perioperatively. So they can risk stratify patients a lot better and say, here's a really high-risk patient, we need to sit down and have this conversation. It's much more difficult in our patients. So what are some of the other sort of patient-specific or family-specific or caregiver-specific factors that also impact on these conversations? I think I've sort of broken them down into what I term enabling factors and complicating factors. So the enabling factors, those that actually help have these conversations, are when you have consensus among the caregivers about the direction of medical therapy. Now, if you think about any patient that we've dealt with in the past decade, I'd say that consensus is a very difficult thing to come to, even in a very experienced and collegial atmosphere that we have here, among surgeons, among cardiologists, among nurses. But if you can develop that consensus, it really helps to have these conversations. If you've exhausted all treatment options, but as I said, we have a lot of, fourth and nine kind of technologies that have been developed relatively recently, and new ones come out every single day, whether it's melody valves, whatever it is. And there's good reasons for wanting to try to promote these new therapies, because there's a certain patient population it will help. But we don't necessarily know who it's not going to help. It's hard to, you can't apply every therapy to every new patient group. Also, if the patient seems to have a lack of responsiveness to aggressive therapies, I think that also helps. You put a patient on ECMO, their lactates don't get better. You're not supporting them well. It doesn't take a genius to figure out that that's probably not the best way to go. Or you've given a patient 48, 72 hours for their function to recover, and they're showing no evidence of recovery. I think we all know what the natural history is going to be there. But sometimes it takes that kind of failure of aggressive therapies to really have these kind of conversations. However, complicating factors on the other side, factors that prevent us from having these conversations. Again, patient age, I think, plays a major role. And again, the study I was referring to was really about young adults, but we deal with kids, too, who have terminal illness. And it gets even harder. And no matter what we want to try to say, I think all of us, being a person who's actually lost his parents in the last year, I can tell you how horrific that is. They were 80. They were in their 80s. They lived a full life. It's a lot harder to have these conversations with the parents of a 5-year-old, or a 2-year-old, or a 12-year-old. In addition, there's a lot of misunderstanding of the illnesses. Here's some place where we might be able to impact the getting to the end of life care discussions. Our families really don't understand the illnesses a lot of times. We think they do because they say a lot of the right words. But I can tell you caregivers don't understand our own illnesses sometimes. They're extremely complex. The anatomy, the physiology, the more we can learn about that, the better we can provide care, the more informed we can be. But if we can't get it all, how can we expect families to understand? So they don't always understand. In addition, we don't do a very good job of kind of giving them the expected life course of their illness, which is more important now than ever. As I said, 90% of these kids are growing up into adulthood. How many of us as cardiologists or surgeons are talking about what life's going to be like when you're 20, 30, or 40? Sometimes we don't have the data, but many times we do. And what we talk about is the acute hospitalization. Or maybe we step it out, a year or two. We're not talking about what they really want to know. Is my child going to grow up to be a happy, healthy adult who's going to contribute to society? When I've been in the ADP sort of situation, I get asked that question a lot. But rarely do we discuss it in this kind of acute care setting. Finally, family discord is something that impacts on this. How many times have we had families who disagreed about what ought to be done? And when you have that family discord, it's really superimposed on a lot of the complexities of care and of what we're trying to accomplish as a caregiver. I think along with that can be sort of shifting medical decision making. You guys see that all the time. I think it's often blamed upon the new team coming on. Right? I've noticed the guy who comes in and removes everybody from support. That's why I'm the nurse's favorite physician. But the truth of the matter is, when you come in with fresh eyes, you do see things that the guys who are in the trenches don't always see. However, there's also reasonable differences of opinion about what should be done. And sometimes a surgical perspective is a very important one, because they may say, yes, I think I do have an opportunity to do something. There are centers where they really will not take on the most complex care, because they know it's prolonged hospitalizations, it's likely to lead to a bad outcome, it's not a very high likelihood of success. But we at Michigan have never taken that approach. We've had a conscious decision that if a family really wants an intervention, and we think there is a reasonable chance of success, you can all define reasonable differently, that we are likely to take it on to try to help that family. You can argue whether that's a good or bad philosophy, but it's been a philosophy that's been here as long as I've been here. And I don't disagree to a large extent, because somebody has to do this. Somebody has to be willing to try to help the family where there is a 10 or 15% chance of survival, but it's 10 or 15%, and they are willing to take that risk. And as long as they're informed about that and what the likelihood is of a bad outcome, who's to say whether or not that's the right or wrong thing? It's not going to make us look good. 85% of the time, we're going to be exactly right, bad outcome. But if that was your child, would you want a place that might give you some hope if there was some reasonable hope? And we've taken that approach. So I think that's also is one of those things that can contribute to a delay in end-of-life discussions, because you're in it to win it. And then, lo and behold, you come out the other side and things look just as bad as you anticipated. It's hard to wrap your head around that. It's hard to talk to the family about no longer do we have the hope that we had prior to this intervention. Okay. I think for sake of time, I just want to quickly touch upon what has been known about other chronic childhood diseases, because there has been better data, unfortunately, in other patient populations than the congenital heart disease population, but we'll go through these quickly. So, chronic obstructive pulmonary disease in kids. There's been a fair number of publications on this. Some of the things that have been barriers to end-of-life care discussions, these families and patients have a high incidence of depression and anxiety. Hasn't been studied in our patient group, but I almost guarantee it's there. Patients' preferences play a major role. In one study, they surveyed patients who were towards end-of-life care. These were patients with chronic lung disease. They were oxygen-dependent, multiple hospitalizations. It wasn't looking good. And the comments were made with things like, I'd rather concentrate on staying alive. I'm not sure which doctor will be taking care of me. And I don't know what kind of care I want. Those are three of the most common statements that were made. So, concern about continuity of care, concern about being left alone, denial, unwillingness to face one's fears. I mean, these sound like reasonable concerns, right? But these are patient-specific issues that we need to overcome if we're going to have these kind of conversations, or family-specific. The physician side was the other side of it. There was a wide range of survival estimates. Interestingly, they talked to a group of physicians and tried to get their estimates about when they thought these patients were going to pass away, and it varied all over the board. I think we'd see the same thing with our patient group. There's also something called framing, which is the ability of physicians to pass on information in a sort of fair and equitable way. And what happens is, I think, often in an attempt to help families and not make them feel like they're alone in making these decisions, we can frame things in a certain way that will dramatically influence patients' and families' decision making. And we don't recognize it. And I think I do it a fair amount. So when I really think a family needs to know that their child is going to die, I can say, your child has a 15% chance of survival. Or I can say, I'm really concerned because your child has an 85% chance of dying. That's the same thing. But the second statement is going to be the one that says to a family, this is starting to get hopeless. The first one sounds like a little bit more hopeful. So how I frame that, and obviously that's just giving a straight statistical statement. But the other superimposed things I have on there, I'm not sure your child's going to be able to see. Or, there's evidence that there might have been an injury to the area of the brain that controls sight. We don't know what that's going to mean long term. Same data. So framing plays a major role, I think, in transitioning to these kind of conversations and helping families come to the same place in talking about end-of-life care. And then finally, communication. I mean, the ability of clinicians, nurses, to really communicate with their families in a way that the family understands. And that's really important because every family and every patient's coming at it from a different perspective, both ethically, socially, sociodemographically, whatever you want to say. We have to try to break down those barriers and talk to the families in ways they can understand, not just about their illness, but about what is likely to happen and end-of-life kind of care discussions. So that's what's been known about COPD patients. There's been a fair amount about AIDS patients. Again, a disease that oftentimes will happen in childhood, but won't take full effect until adulthood or adolescence. It's interesting when they surveyed these patients, the patients had very few barriers about talking about end-of-life care. They knew this is a terminal disease, and we forget this, but it is still a terminal disease. There's no cure for AIDS. But what we've done with great advances in drugs is we've delayed the full onset of AIDS in patients living with HIV for a long period of time. So the patient said, we're happy to talk about this anytime. We know we're not going to survive. It was the clinicians that had most of the barriers to talking about end-of-life care. Surveyed them, the number 1 and 2 comments were, well, the patient hasn't been very sick yet. Right? And the second one is, which is really interesting, is the patient isn't ready to talk about end-of-life care. Patients didn't say that, the physician said that. So it is a very difficult conversation to have, no matter who you you are. But the patients in many instances are ready. It's the caregivers that aren't ready. They looked at cancer patients, childhood cancer survivors. The number one risk factor for not having an end-of-life conversation was that their medical care had been received in major academic centers. So if you got your care in a community hospital, somebody talked to you about palliative care, end-of-life care. You got it in the University of Michigan, people weren't talking about it. Now, don't know the exact reasons for that, but I think we can all guess. Here's where the technologies exist. Here's where patients come to be cured. You don't get referred from South Dakota to Michigan to be told you're going to die. You're sent here for the miracle Dr. Beauvais surgery, right? It's very straightforward. These are difficult transitions to make, and we're already dealt a losing hand by being a major referral center when it comes to these kind of conversations. Cystic fibrosis. There was a study in 2009, retrospective review of all deaths from cystic fibrosis over a 10-year period in a very large center. They studied 212 patients with cystic fibrosis, 40 of whom died. The mean age of death was 29 years, so very similar to our patient population. 5 patients died post-lung transplant, so if you know, the same analogy that we used for the congenital heart disease study I referred to earlier, we removed those from the analysis. 87% therefore died of progressive disease. This is the group we want to look at. Of those 87%, 11% died at home, 89% died in the hospital, so maybe that's more in hospital than we'd like to see if we were talking about our elderly patients. But when they actually got right down to it, it was interesting. It was the patients that wanted to come to the hospital, even if the plan was for them to die at home, mainly because they were so familiar with the caregivers and the environment. This is where they felt comfortable. So the idea that we create these home deaths is great, but for certain patient populations, this may be the better environment. So I think we can take that with a grain of salt. What's interesting is only 1 patient died in the ICU, and 83% died in palliative care. So to me, this is more the perfect model we should be trying to achieve for congenital heart disease patients. Okay, so from another study in the International Journal of Cardiology in 2010, they looked at end-of-life discussions in congenital heart disease patients. This, again, wasn't really focused on the demographics and the risk factors for lack of palliative care. This was really a conversation with the patients themselves, one of the few other studies that I can find in the congenital heart disease patient population. What they found is that in these patients, most patients favored earlier discussions in the course of their disease. And that was independent of any disease complexity, which is interesting, and independent of any socio-demographic factors. So it didn't matter who you were, what your age was, what your disease was. End-of-life discussions from the patient's perspective earlier in the disease process, when they had some control over it, when they could have logical discussions with the caregivers. In contrast, however, in the same study, the healthcare providers reported that the frequency of discussions was directly related to the complexity and severity of the disease. So again, we think we know what the risk factors are for death. We have no data on that. We have no models to tell us who's going to die and who's going to live. We're very poor at diagnosing or at anticipating who's going to die and who's going to live. Nonetheless, we say we'll have the conversations with those with more severe disease where we think we know who's going to die and who's going to live. So at the end of this little session, I just wanted to talk about some of the potential benefits of earlier end-of-life discussions from the literature, as well as a little bit of data about our own palliative care experience here at Michigan. So there are 2 publications out in 2008 and 2010 that basically showed that with less aggressive application of feudal interventions, including ICU care, and earlier palliative care referrals, there was an improved quality of life for the patients and families involved. There was better resource utilization, and the patients felt and the families felt a much more positive experience during the dying process. And I think, again, we all assume that's the case. There's not a ton of data about this, but there is some data out there to suggest that's the case. So what about at Mott Children's Hospital? So the folks in the palliative care team, Ken Pittich and Maureen, were nice enough to share with some of the data that they've recently put together as part of a larger pediatric palliative care research network. And from their consult services started back in 2005, we seem like it's been there forever, but it really hasn't been. It's been about 7 or 8 years. And in terms of their diagnoses, 40% of the diagnoses that they see are congenital, which includes us, and about 12 to 17% of their diagnoses are cardiac. So we represent a fairly significant population of their patients. When you look at the outpatient, inpatient new consults, or inpatient follow-up consults, those have continued to go up progressively since the service began in 2005, and now they see over 400 patients in outpatient consult, inpatient new, and inpatient follow-up consults. Interestingly, when they looked at through this palliative care network at 515 patients who received pediatric palliative care, and they looked at how many of those patients are alive over time, of those who entered the study, of those 515 patients, surprisingly about 75% of them are alive 1 year later. So the take-home message is palliative care is not end-of-life care for most of our patients. So when you think about entering patients into palliative care, we can reassure our families that we're not talking about a discussion to anticipate death in the next week. That's probably too late. That's that futile end-of-life care that we all understand. What we're trying to do is be able to manage this in a timely fashion that allows families and patients to adjust, and we can reassure them that in our patient population, 70-75% of these patients will still be alive a year later. So there's multiple opportunities to intervene in a very positive way on this patient population. When they chose 45 selected patients from this group in Michigan who were alive 2 months after their palliative care consult, they looked at resource utilization, and I think this is a very important understudied area because, as you know, given the current financial picture, cost plays a major role in decision making. And at some point or another, some of these high-end technologies may be resource limited, and we have to choose very wisely as to what we're able to do, and we have to almost justify who deserves application of these high technologies. We can't use them arbitrarily in this day and age. So they looked before and after consult at these 45 selected patients. And before the palliative care consult, the average patient was hospitalized 23% of all the days in the preceding 3-month period. So think about that. So 1/5 of the days over a 3-month period they were hospitalized. This was 20 days per patient per quarter, or about 900 total patient days per quarter if I did my math right. Following the palliative care consult of these patients who were alive 2 months later, the average inpatient time decreased to only 10% of all days, or about 9 days per patient per quarter. This saved about 11 days per patient per quarter, hospital days, or about 2,000 total patient days per year. Annualize that. That's a lot of hospital costs. In addition, the ICU stays decreased by about 400 total patient days per year. They went from 4% in this same 45 patients to about 1.5%. So when I look at the effectiveness of palliative care, not just from the caregiver's perspective, the patient family's perspective of feeling like the experience has been more beneficial for them, these to me are very objective data that suggest that we're also using resources in a much more intelligent way. Because that means that there are 400 total patient days more for patients who have curable disease that need the ICU and need operations, and whom end-of-life care discussions aren't appropriate at this point, and where we can actually intervene in a more acute way. So, in conclusion, I think that there are 2 ways that we often have these conversations with families from a caregiver perspective. One is we talk to the families and someone says, I want you to do everything. Has anyone ever heard that one before? I think that leaving that at that level permits potentially harmful vacillation in the face of critical illness. And I think whenever we feel that there is this idea of do everything, we are obligated to have additional conversations to help families understand that's unrealistic. We can't do everything. You can't do end-of-life care and transplant simultaneously. You have to understand that it's unrealistic, and medical care can go in several different directions, but not at the same time. So what we can say is that what we are hoping for, what we think we could do everything to hope for a specific outcome. and find out from the families what their hope is. Because if we have a very predefined idea of what they're trying to achieve, then when we start to see we can't achieve that anymore, then it's no longer appropriate to do everything. So we can hope for recovery, we can hope for comfort, we can hope for dignity, but we can't necessarily hope for everything at the same time. But I think oftentimes we hear that, and our crutch is to say, okay, well the family wants to do everything, so I'm obligated to do everything. And I think that's truly our crutch, because it makes it easy if the family says that, right? Because then right on down to the last breath of the last CPR, we're going to do everything. The alternative is to say, there's nothing more that we can do. I've said that many times. But I've learned in the past 5 years that we can always do something. And what we can do is continue to participate in end-of-life care. And that isn't doing nothing. That is doing something. It's just doing it different something. Right? So there was this great quote that I got from an article in this past year in a palliative care journal that I thought applied to us. Is intensive care is composed of both invasive care and intensive caring. Even if the former is failing, the latter can continue unabated. And I think that's sort of the take-home message. And I think that it is incumbent upon all of us to sort of relook at our practice, think about end-of-life care, the barriers and the factors that help us get to these kind of difficult conversations, and come to consensus among our team. But then we need to get with the families and have these conversations. Somewhere deep down, they know. They're prepared for it earlier than we are. And I think it's important for us as caregivers to provide this. Now, we often use a palliative care team here, and I'm not against that. But multiple studies have shown that caregivers in this environment can learn this too. And we can do this. This is more about knowledge of what the barriers are and understanding of what your own biases are, and making sure that we are, again, serving our patients and our families. And I think the palliative care team has appropriately become a bit of a crutch, but I think that we can do better ourselves in this. And honestly, if we're really doing it well, we probably don't need a palliative care team in the majority of cases. So first off, I want to say, what do you guys think of the talk?
It's great.
Do you think that there's an audience in critical care medicine, remember these are adults and pediatrics as well, that would understand and appreciate these kind of insights? Okay, good. Thank you. Second of all, what kind of questions do you guys have?
How do we get our team like more educated, especially the physicians, how to talk to?
Well, like with everything else, I think that there needs to be training. You know, I think that the palliative care team probably could spend more time educating groups like us than providing the service, because I think the service is important, but I think actually the education, ongoing education is extremely valuable. Training a new generation of people, so we have people coming through like Aaron wants to do ICU. Melissa is doing ICU, and they both are very interested in palliative care and doing formal rotations with the palliative care team. So I think there is more of a sensitivity and understanding of the importance of this in this day and age than there was 5 or 10 years ago. So that's a step. So probably turnover of a generation of dinosaurs like myself, who didn't train in this kind of era, who dealt with trying to get kids to survive and understand morbidities now, or business. I think those are some of the things that come to mind.
That's happening.
I think it's happening. I think it's happening, but I think we can continue to do more of it. I think we need to do more on the nursing side too. Yeah. Because I think you guys have a lot of insights, but you also have a lot of barriers. You know? So.
Thank you, Dr. Charpie.
Thank you very much.